20 minutes, and we should be finished at 2:30. So the first case will be presented by Professor Tarek El-Baz.
I'm really honored and very happy to have such a distinguished panel. This case is just meant for education within our CME vision. The story is about a previously healthy 35-year-old female. She was seen by her GP because she had a knee pain, right side, and she had some fatigue. She also mentioned that she was passing unusually large amounts of urine. 1 week earlier, she had a cold. Her GP decided to give her amoxicillin, 375 milligrams BID, and some paracetamol, 2 grams a day. She was noticed to be a little bit pale. She wasn't edematous, and she denied any bleeding from orifices. There was no evidence of gum hyperplasia, no lymphadenopathies, eruptions, or other skin lesions, and her blood pressure was 166 over 103. She had an unremarkable cardiopulmonary examination as well as the abdominal examination revealed no organomegaly or tenderness or any other abnormalities. So let me just throw the first question here on clinical grounds. What are the possibilities and what possible labs would you initially order?
Are you asking the panel or are you asking the audience?
Asking whoever wants.
Asking the panel.
The panel should...
I want to ask young nephrologists at the back. They're falling asleep in the back.
That's what I want.
So,
You want me to say it again? 35-year-old female, she was previously healthy. She had a right knee pain, and then she had fatigue. Her GP thought she had a cold and gave her some amoxicillin and paracetamol. On examination, she had nothing but a little bit of pallor, but she was passing unusually large amounts of urine.
What medication did she take for her knee pain?
Well, she did take paracetamol.
Is she taking non-steroidals?
She did take paracetamol the week preceding seeing the complaint.
That's all.
That's it. Let me take the slide back again. 1 week earlier, she had a cold and she got the antibiotic and the paracetamol. I didn't mention any kind of protein. I just said she noticed that she was passing unusually large amounts of urine. That's what her doctor, her GP said. There is plenty of analyses coming. Would you like some? Would you order something? Any lab at this stage? Okay, that's a good suggestion. Okay, let me see what I have. That's her hemoglobin 7.4. Sedimentation rate was high, 88. Serum albumin, 4.3. Serum calcium, 11.5. And definitely creatinine was abnormal, 1.9. And look at her urine, it was alkaline with glucosuria, uric acid crystals, and the urine dipsticks was negative for proteinuria. Okay? That's what I have to show.
So she's hypercalcemic, anemic with a high ESR.
And a renal insufficiency. And she's 35 and previously very well.
Excuse me, but the electrophoretic pattern was normal?
I didn't come to that yet. Her renal ultrasonography showed 2 normal-sized kidneys without signs of obstruction. And at this stage, she was referred to the nephrology department, and she received enalapril for hypertension, and calcium channel blocker also was initiated, and a renal biopsy was ordered. Do you think it was right to order a renal biopsy for that patient? Show of hands, yes, no? Yes? Yes, for a biopsy. You would biopsy such a patient. She didn't have any proteinuria.
Can you show us
On the dipstick.
ورينا البايوكيمستري تاني والنبي طارق.
Yes.
The biochemistry. So her creatinine is raised, and her urinalysis is negative. She's 35 with a creatinine of 1.9.
Yes.
So who would biopsy her? Show of hand. Now the question is who would biopsy her at this stage? Dr. Lina.
Of course.
Of course. Khalas, we would biopsy her.
The
What about the people who didn't reply? Who would not biopsy her?
Would you like to get a urine sediment first? What's the hematuria? Were they dysmorphic red blood cells in the urine? Did you see red blood cells?
That's a good suggestion, yes.
So
We don't depend so much on the dysmorphism because in this country we don't have this dark field microscopy. We just depend on having hematuria tests. Dipsticks just was done. Yeah, she didn't have hematuria. She didn't have hematuria.
What about AD?
These are the findings that. Maybe I come to it later.
خلاص عملت بايوبسي مش كده؟
Okay, I biopsied the patient. يلا عشان الحالة اللي بعديها ما تضيعش وقتكم. Why was the biopsy ordered? I think Professor Nahas summarized this. Did you? Why the biopsy was ordered?
Yeah, we said the biopsy was ordered because she had a creatinine of 1.9 at the age of 35 with hypercalcemia
That's it.
and polyuria.
Can we speak, sir, or we don't allow to speak or discuss? It is according to the panel. I don't want to speak, but just the plan. Shall we do any opinion or?
سوري يا احمد قول تاني مش سامع.
نقدر نتكلم يا بيه ولا ما نتكلمش؟
لا ده انت تتكلم قوي بس لما اقول
انت
لك
بالذات
تتكلم.
لا. انت بالذات لا.
احنا في ديمقراطيه
دي
دلوقتي.
للدكاترة النونو يا احمد مش ليك.
احمد you have a comment?
That's the biopsy. That's the biopsy. If it makes anything to you, I'm sorry, Nina. That's the best I could show.
It's good enough.
I'm sure. I'm sure.
Dr. Lina, would you like to comment on the biopsy?
Sure. This is an HNE. It's working. It's an HNE section, and you can see 4 glomeruli. Some of them, they don't look healthy actually, maybe ischemic. What's really, can attract your attention is the interstitial and the tubular process. I can see a cast here, and this cast is a little bit abnormal. So it's mainly interstitial I can see, and interstitial and tubular.
So there's a lot of round cell infiltrations in the interstitium. It's taking on a chronic form of interstitial nephritis together with evident tubular atrophy. I didn't have in the report anything saying the glomerulus are affected, but you know better. That's what I had as a report about this pathology.
Any granulomas?
Not in this.
In the rest of the biopsy.
No.
Oh, that's,
This is the most consistent cut.
that's it.
Yes, that's it. So the light microscopy showed 22 glomeruli with no signs of sclerosis or crescents. However, chronic tubular interstitial nephritis with moderate tubular atrophy and tubular interstitial lymphocytic interstitial inflammation was present. In view of the previous lab results, what does this report suggest? Is this okay, the question at this point?
Chest X-ray.
Chest X-ray.
She didn't have a chest X-ray, not that.
She had a kidney biopsy and no chest X-ray.
There were no symptoms, خالص.
Huh?
ما كانش في symptoms to suggest a chest X-ray.
Okay.
Didn't think of a vasculitic lesion. She
Dr.
didn't have
Ahmed
symptoms.
Gaber, تفضل يا أحمد.
Can I have a comment, please? A little bit eccentric, because
We know.
you already said that it is 1.9 creatinine with a lady 35. We don't have a lot of history. What sort of creatinine a month ago? Just before rushing to do a biopsy, the calcium was 11, but we don't know the phosphorus, the PTH. Before I send to do a biopsy, I must have a differential diagnosis. What I expect from the pathologist to say, and we don't do a differential diagnosis. I have a lot of things which is missing. The uric acid has got a mention. It has got a lot of urate. And the chest X-ray, of course, before doing the biopsy. That's my comment.
If you have a 35-year-old with a GFR of 30, which is probably the GFR she has, of a known etiology, wouldn't you biopsy her?
I don't have enough data to suggest that she is a CKD. We only have one creatinine, 1.9, if I am correct.
Maybe she's an AKI, not a CKD.
Right, in this, that's my point. Before doing the biopsy, I must have a lot of other data to support sending the patient to do a biopsy.
Okay, let's suppose her chest X-ray was fine and her serum phosphorus was a little bit high in accordance with the serum creatinine. If that's what you ask.
We have a drug which causing hypercalcemia.
You can
Because
think of
simply,
that. You
if I
can,
confronted with this lady, she may have a drug which causes hypercalcemia,
Sure.
an interstitial nephritis. I will deal with this and don't do biopsy and the patient will be fine.
sure. Okay.
يعني أحمد بيقول we need a comprehensive clinical history, we need a comprehensive physical examination before we make a decision on whether to do a biopsy. Okay, but this is a case presentation يا أحمد فبنحاول
ما
يعني
هو
نلخص.
ما ينفعش يا ابو حميد.
Okay, Dr. Magdi.
Yes, please. The thing, before taking this biopsy, I could make some profiles like if this lady is diabetic or not, fasting blood sugar, alkaline urine.
No, she wasn't diabetic. She wasn't diabetic. I showed
The
you.
immune profile of this patient.
Yeah.
The immune profile of this patient before taking this biopsy. I have a lot of battery of investigation.
You must have clinical suggestions to order the battery.
Okay, shall we assume that Dr. طارق ما قالناش على أي حاجة في
حاجات كتير أوي
البايوكيمستري
قدام.
أو الهيماتولوجي abnormal مش
Yes.
كده ولا إيه؟
I accept الكلام ده.
Yeah?
Yes.
مش مخبي حاجة
لا
عنك.
لا لا لا.
أكيد.
Absolutely.
أكيد.
I swear.
طيب.
I swear.
Okay,
I
كمل.
swear. It's you and Monticelli. I can't lie. It's impossible. No. It was normal. She wasn't diabetic. And I just said that previously to this history, she was very healthy. 35. حاجة يعني جميلة أوي. يا ريت. Yeah. No, she didn't have basilophiluria. علشان بتفكر في drug induced, and all the drug that she took was the NSAID, the paracetamol, and the antibiotic, the amoxicillin. Maybe we come to this. I'm just reminding you again of the labs. I remind you again of the labs.
Professor Lehman, you see controversy or sort of contrast between presence of severe interstitial reaction and absence of cellular sediment in urine?
Yeah, the most important thing when you have a renal biopsy is to answer the clinical question.
No one was really
يعني
addressing a very important point in this case, which is this urine with glucosuria, and she's not diabetic. She's not diabetic. You see? And the urine was alkaline. Maybe I didn't put blood gases here. And this was a classical picture of Fanconi, and Fanconi may be a primary disease, and this is Dr. Fanconi. He's a Swiss pediatrician who described this syndrome. You may have it as a congenital form or a secondary form occurring in various systemic disorders. So this urine did suggest real tuberculosis Fanconi syndrome. Now, what's making Fanconi syndrome?
What is the evidence that she's got Fanconi syndrome? Before you tell us about Fanconi syndrome, you would expect 1+ glycosuria with this degree of severe chronic tubular interstitial changes.
You would expect?
You would expect glycosuria 1+ if you have diffuse tubular interstitial atrophy and fibrosis. So that is non-specific.
Non-specific for the Fanconi.
The urine alkaline, yeah. What was the pH of the urine?
Was alkaline.
What was the pH of the urine?
I don't have
Okay.
Hypercalcemia was confirmed, Professor Tal.
Pardon?
Hypercalcemia was confirmed.
Hypercalcemia was there, definitely, from the beginning. Hypocalcemia, yes. But this is not, this is a secondary Fanconi, not congenital, not the primary Fanconi.
Have we looked for BTH?
That's the point.
BTH, parathyroidism.
What's this?
Was it?
I think it would have been worthwhile, and during the work of PTH was looked upon for the hypercalcemia, and it was in the normal range. The PTH was normal.
If PTH was normal, I would worry.
Yep.
Because you would expect the PTH to be low in the face of this level of serum calcium. So a normal PTH with this level of hypercalcemia will be of concern of possible hyperparathyroidism. Can I ask you what was the level of the PTH?
No, I don't remember level, but it wasn't an abnormal level. But let me ask you a question. If you had this renal insufficiency, wouldn't you expect any kind of change in the parathyroid, even to keep it in the range of normality, not dropping? If this is an acute lesion? What?
How to exclude myeloma?
Myeloma. We didn't. We didn't. We didn't.
Why don't we try to exclude it? Because secondary it's not for fully.
No, the age is not against.
So, because Gamal Saadi is asking why, so I'm asking what are the further investigations that you would like to order? So Professor Saadi is saying we better have and plasma protein. That sounds good because you have a case of hypercalcemia. The patient is not hyperparathyroid. It's not hyperparathyroidism. I don't have any clinical suggestions, and I didn't tell you any data that she has a metastatic cancer breast, for example, to explain the hypercalcemia. She's not taking ipamutine or any drug that's leading to hypercalcemia. So what's this hypercalcemia coming from? But you have to remember the patient was 35 years old. Okay. So we had a 24-hour urinary collection that was done. Maybe أنا خليت حاجات قبل حاجات. And the results showed a rather heavy proteinuria of 8.7, while the urinary albumin was 129 milligrams.
انت قلت لنا اليورين اناليسيز ما كانش فيها بروتين
Yes,
في الاول.
yes, I did. The urine sticks, the algo sticks.
Okay.
And this is the teaching point.
So there was a discrepancy between
Yes.
a negative albu stick and a positive 24
That's the teaching
hour.
point
Okay.
I wanted to present.
That's very
That putting a
interesting.
dipstick You find no proteinuria because it's checking the albumin, and this is not selective proteinuria. It was tubular proteinuria. When I checked for 24 hours, I found heavy proteinuria. So let's not depend on the dipstick and say the patient doesn't have proteinuria. So constantly elevated serum calcium levels ranging between 11.6 and 12 milligrams were noted. On the other hand, there were no signs of hyperphosphatemia, hyperkalemia, hyponatremia, or acidosis. A normal dipstick, and this is the teaching point, does not exclude an abnormal urinary protein excretion because this is only checking for the albumin while the patient had really heavy protein. وانا كنت قلت لك الحالة دي قبل كده ولا يا شيخ؟ انت طلعت. What further investigations would you like to do? Already Professor Saadi had mentioned that we were to do an electrophoresis was performed and showed marked Benz-Jones proteins with excretion of light chain type kappa at the very heavy concentration of 8 grams. Also, a plasma electrophoresis showed the classic M component of the free light chain type kappa with slightly depressed levels of plasma IgA were noted. Okay. Myeloma, when you take the bone marrow infiltrations of the plasma cells, it has to be a little bit more than 10% plasma infiltrations of the bone marrow. And just to remind you, now.
But Dr. Tare, please, I will go back to the biopsy.
Okay,
First
okay.
thing, I will go back to the
الحقيقة
biopsy.
البيوبسي كانت illustrative جدا and no one really remarked about
No, it's not straightforward. No, it's not straightforward.
لا
But it
يعني
has
البيوبسي الكات اللي كان موجودة كان فيها it had a cast.
يعني-
It had a cast
يعني we,
and a rather biggish cast and a rather fractured cast, and this is very much pathognomonic.
But did you do any stains?
This is the histochemical staining showing the.
Dr. Volker has a comment.
Well, the other possibility is, of course, number one, the elevation of the serum protein was not that striking to begin with. 1.9 was high, but normally with a cast nephropathy, you expect acute renal failure much higher. So that's number one. Number two is the patient had significant, so in the end, nephrotic range proteinuria, which normally is not a sign of a simple cast, myeloma cast nephropathy. So in this scenario, then, the differential diagnosis includes a monoclonal immunoglobulin deposition disease or light chain deposition disease with deposition of light chains along the glomerular basement membranes and tubular basement membranes. And that would be high on my list as well. But that is associated here with
I believe you are absolutely right. It was a light chain disease, and all those anticoagulant antibodies are fixed at the basement membranes or brush borders of the renal tubules. You can see them here from the histochemistry, the anticoagulant antibodies. And the diagnosis as such was a light chain multiple myeloma. Light chain, like Professor Nicollet said, and just this illustrates a sad fact that although rare, وكنت عمال اقول لجمال سعد الكلام ده 35 بيقول لي وماله. It is rare. We don't see myeloma and this serious malignant disease at that age. But unfortunately, this is a real case, of course. Unfortunately, this young lady did have multiple myeloma, light chain disease. Light chain disease is rather difficult to diagnose. I'll just take the pathology back to show.
Tari, did she have amyloidosis?
This is what I had from the pathology. No, she didn't have amyloidosis, no.
Did you stain the biopsy for amyloid? Because polyuria can be an early, well, it's hypercalcemia, but it can also be a marker of amyloid deposition.
As a matter of fact, the pathologist only stained by the immunofluorescent. He looked at the discussed
Any possibility for light chain?
for the light chain.
By IRL.
Light chain, yes, light chain. And this cast, maybe it's not so fractured, but تخليش شوية كان في واحدة تانية فيها fractured cast يعني. بس عشان أعرف إن أنت قاعدة في المكان. Fractured casts are very important and very pathognomonic of cast nephropathy, although this is not a cast nephropathy. Like Professor Nicollet said, you would expect a very serious form of acute kidney injury, and they present really with high serum creatinine, but light chains may present as such with slowly progressive form of decline.
Dr. Magdi.
انا بس احب اسال الزملاء الباثولوجيست لو ده هل في بلازما سيلز ولا لا؟ لان دي بتفكرني بحاله من 30 سنه شفناها جت نفس المنظر، ادينا له اي بي بي دخل في الانيوريا، عملنا بايوبسي طلع هذا المنظر. ما كانش حتى كالسيوم عالي، كان الفيليا بس. الحقيقه الحاجه اللي كانت واضحه قوي في باثولوجي كان في بلازما سيلز. انا مش عارف بس لو
Usually they don't, the plasma cells do
The
not
question is, was there plasma cells in the interstitium?
diagnostic.
The plasma cells don't infiltrate, right, Lina?
Yeah, you don't
They
need
don't
plasma.
infiltrate the kidney.
Take it for lymphocytes.
لا لا you don't
No,
you don't
you
need
wouldn't have plasma cells in
at
the
all.
kidney. You would have them in the bones. You would have them in the bone infiltrating the bone.
يعني البيوبسي دي مش indicative خالص المايلوما او بلازما سيل اسكريزيا.
I can't recognize.
It's difficult, it's a
there is
chronic
plasma
عشان
condition.
يوصل لنا الفيليا بهذا السبب. دي لازم تظهر حاجه.
You don't need plasma.
In normal cases of plasmacytoma-associated renal disease, you practically never find lymphomatous infiltrate in the renal parenchyma. Yeah, plasma cells or whatever. That is extremely rare. You have the effector arm of the precipitation of light chains or heavy chains in the different compartments.
Dr. Tarek, I think you asked for immunostain later on when you found this band by immunoelectrophoresis and when you found these skeletal changes of multiple myeloma. You asked for this special immunostain.
The immune stain was suggested by the pathologist, as a matter of fact, due to can't find anything else than interstitial lesion and the hypercalcemia, and it was a suggestion made by the pathologist, and it was very bizarre with a 35-year-old lady. We didn't have the results yet of the immunoelectrophoresis at that time, but the pathologist was Allah yarhamullah, Dr.
We've
Magdi
got
Francis.
5 minutes.
No, this is.
You finished?
I finished. I'm finished.
A comment by Professor.
No, just a short comment because this is a very instructive case. But I think that whenever we see a patient with hypercalcemia and anemia, independently of age, we should try to perform an electrophoretic pattern and an immunoelectrophoresis because the possibility that such a patient has an underlying myeloma very high. And I think
About the age, Professor
particularly
Botticelli?
important the message that the dipstick doesn't say anything because dipstick just measures.
That was an important point to mention. It meant nothing. Nothing. And it was very confusing. If I was going to depend just on the dipstick, I missed the case. But the question I'd like to ask you, Professor, is the age of this patient. It is rather unusual. As a clinician, would I put it in my differential diagnosis?
You're perfectly right.
That's the point.
I was impressed because I saw some few patients very young, including the daughter of a good friend of mine. She had myeloma at 28 years.
20 years.
And we were astonished when we saw the red blood cells and the electrophoretic pattern. And I couldn't believe. Fortunately, it was. So it may happen, unfortunately.
Thank you. I hope I haven't been too confusing to
So a
everybody.
few questions, but 3 important teaching points for the young nephrologist.
Yes.
Negative dipstick doesn't rule out light chain and Bence-Jones proteinuria. If you have anemia, as Professor Ponticelli said, and hypercalcemia, think of monoclonal gammopathy, do a serum protein electrophoresis, do free light chains, and do a bone marrow biopsy. And 35 is young, but you ought to look for myeloma. 2 questions, Walid and Ahmed Abdelhadi. Walid Masoud.
Just for a pathological point of view of the casts. The cast present, usually the myeloma cast is lipophobic and does not take this bright stain, which looks like a highline cast. Just this is my comment.
It was right. This is not a cast. This is not the myeloma cast, Walid. It was. Did you see any giant cells? Did you see any
With
giant
the
cells?
tissue fibrosis is there, with the infiltration, at least congested.
Cast
I
nephropathy.
think it was congested in the report that you got from the pathologist.
No, there was another case. Me and Francis, we spotted many cases of myeloma together.
For me, this would at least be congested. Maybe.
Thank you. Last two questions, Ahmed. And
I have confronted by such a case, but the thing which made me postpone the kidney biopsy, that I would have confronted by bone marrow biopsy. So I chose to expose my patient to one intervention technique rather than two intervention technique or invasive technique. That's so the kidney biopsy here didn't change the modality of treatment or the differential diagnosis.
yeah, that's an interesting point. We always have this discussion with our hematologists, and they always ask us, even when we make the hematological diagnosis of myeloma, to do a kidney biopsy, because they said if it's myeloma with renal involvement, depending on the severity, it may affect the regimen they use in chemotherapy. But I agree with you, myeloma is myeloma and impaired kidney.
Sometimes light chain disease in particular, light chain disease, you have less than 10% infiltrations of the plasma cells, and it makes things really very difficult because you don't find the real
Usually, the
infiltrations.
patient here will not be anemic. If he has light chain disease without bone marrow manifestation, he will not be anemic. I think so. That's my comment.
Okay, I want to add, from the pathology teaching point of view, if you have myeloma, how myeloma can present in the kidney? You can get amyloid, you can get gas nephropathy, you can get light chain disease, and at the end, you can get, of course, the plasma cell infiltrate, which is the last. Do you want to add further anything? So these are the presentation of myeloma in kidney biopsy.
Last question, Professor Naveen Suleiman, pediatric nephrologist perspective.
You don't have myeloma in kids, of course, no?
Microphone is switched on. Thank you very much. Can I ask the last comment by Dr. Volker? Do you do a kidney biopsy when you have a diagnosis of multiple myeloma, clinical and hematological, and a creatinine of 1.9 or 2?
Likely, yes. But of course, I would look at this case from a slightly different angle. And I think if you go back to the original presentation, I think it illustrates that you chose the route to do an invasive procedure. So a real biopsy was taken with all the risks and the costs. And then, as Dr. Ismail pointed out yesterday, the next step ideally should have been to work this case also up at that time point with immunohistochemistry. And you would then have made the diagnosis unexpectedly that there is deposition of light chains in the kidney. And thereby, of course, also you would have avoided all the other tests that were done, and some tests I'm sure we didn't hear about were unnecessary.
If we had have done the electrophoresis in the beginning, then it would have been such an interesting case and confusing.
But in general, I think it illustrates that
finished.
It illustrates that unexpected findings can be made, and then by just doing the routine workup of a renal biopsy, you can find much more than you expect.
Thank you very much. Thank you very much, Professor Abbas.
Our next speaker is very well known to everybody, and she is a dear friend to me, Wissam Ismail. She's Assistant Professor of Pathology at Beni Suef. She is ISN Renal Pathology Ambassador and the head of the Arab Renal Pathology Club. She's presenting us with a very interesting case.
Why wasn't he biopsied when it went from 2.8 to 3.5? Why did you have to wait until the creatinine is 4 to biopsy him? So Khalid, انت مسؤول.
What's the native kidney disease, Dr. Osam, please?
IgA nephropathy.
IgA nephropathy.
Diagnosed in USA in George Washington University. Yeah,
that can be considered to visualize it.
We had graft dysfunction, 3 weeks post-transplant. We had the patient presented with fever and diarrhea and UTI normal.
I would consider at this stage that we treat as a rejection infection. The diagnosis of thrombotic microangiopathy might be related to a thrombotic disease rejection or drug toxicity or a viral induced HUS. So we need to differentiate because the treatment will differ according to this differential diagnosis.
Of course, it is a possibility.
I think if we try to make logic simple, why not CMV infection that induced an acute rejection, which is
very nice,
common at this time of the transplant. And I am defending Dr. Khalid in doing a biopsy a little bit late. Of course, this is not correct. He should have done it before, at least before giving the shots, because shots can alter the pathology. Or at the same time, he should have done the biopsy and initiated the steroid immediately after the biopsy. But there are, in the practice, we can do, we can give shots without biopsy, and this is called acute rejection, not biopsy proven. Not biopsy proven gives a weak diagnosis, but this is a practice, and it's not wrong.
Continue.
Yes, in conclusion, like my professors, all of them said that TMA possibility is high, hemolytic uremic syndrome possibility is high, but we haven't any data about the bilirubin level, the destruction of the red blood cells, but thrombocytopenia is present. It is not the TTP. At the same time, before biopsy, I can save the patients by doing something, pulse steroids, or alternative pulse with plasmapheresis. This is therapeutic trials. Before the biopsy.
Okay, may I comment on this? Because thrombotic microangiopathy doesn't have to present with a systemic manifestation.
I know, maybe.
Yes, so you can simply have it renal isolated.
Of course,
okay,
right.
So we have a thrombotic microangiopathy, either infection-induced or antibody-mediated rejection. We have the possibility of a CMV infection, which induced acute rejection. This is basically the two conditions.
There is another possibility.
Dr. Azam?
Okay. There is another possibility. Maybe IgA nephritis recurred again in this graft. I know that the duration is short, but it may be recurrent. And when this patient developed infective diarrhea, it is known that affection IgA, and this is the cause of the hematuria.
Okay, I think we need to move on to the slides, but I got the third point, which is that we could have recurrent disease.
The last statement, the presentation of rising of serum creatinine may be AKI due to IgA nephritis, one of its presentation. Sure.
Yeah, of course. Okay, first, the biopsy was an inadequate biopsy, and it had only 5 glomeruli and half an artery. It might seem reasonable. You can see that here is the glomerulus, and the glomerulus looks to me unremarkable, so there were no signs of TMA. The arterioles were also fine. There were no sign in this biopsy that we had any form of thrombotic microangiopathy. But we did have interstitial edema, we did have lymphocytes, and we did have tubulitis. For those of you right, and you can see this is the tubular basement membranes, slightly greenish, and all of these black dots are the lymphocytes crossing the tubular basement membrane, and this is what we call tubulitis, and this is the hallmark of cellular or cell-mediated rejection. look at the other. There were also evidence have to have typical inclusions, but they could be a bit enlarged. They do look a bit different than the normal nucleus. So this is what we call cytopathic changes. We do not see it only in viral injury, but we see it as a form of repair after tubular injury. So if we're not sure what is the cause, we just say the term of that we do have some cytopathic changes in the kidney. You can see again the infiltrate, which was actually around 30% infiltrating the core, and the tubular injury. His peritubular capillaries were nothing in them. Again, this is an evident tubular injury and the tubulitis, and his C4D was negative. At the same time, we received the urine cytology for this patient, and it was negative for decoy cells. So the morphological diagnosis came. This was an inadequate biopsy, probably compatible with an acute active tubulointerstitial rejection. It's C4D negative. It's BAMF type grade 1A category 4, which is T cell mediated. Around the same time, the pathology results showed up, the virology screening showed up, and the patient was seropositive for CMV IgM. He had received IgV ganciclovir during hospital stay and was maintained on ganciclovir according to his EGFR. Following the biopsy, the patient received ATG 100 milligram per day for successive 5 days, and his serum creat landed to 1.1 milligram % with increased urine output, and he was discharged. Before, what I saw in the biopsy was not just suggestive to me that this was a viral-induced inflammation or a reaction, that this was rather a rejection with possibly a concurrent viral infection. No, they didn't do SV40. Actually, when the decoy cells were negative, I didn't do any SV40, especially that I did doubt that the patient has CMV because of the systemic manifestations he had, which is not common to see with polyoma. 1 month later, the patient was readmitted again because this time of anuria. His serum creat was 8.2, hemoglobin was 6%, platelets were 48,000, and serum LDH 985. And a second graft biopsy was performed. This time, they did the biopsy on the spot, but of course, as you could expect, that I didn't know anything of these data. I just thought that it was a follow-up biopsy on the patient. So, any ideas before I proceed with the biopsy? The patient was supported by hemodialysis, packed red blood cells, transfusion, and steroid shots, and PRA levels were, reactive antibodies were 0%.
In some way, this patient had an acute rejection and a severe infection.
I can say that this patient had an acute rejection, but I don't have hard evidence that there was CMV infection in the kidney, just a doubt.
Okay.
Excuse me.
Now, I'm still surprised by the fact that this patient is anemic.
Me too. I didn't know this data about the patient except on the presentation. True.
And again, I feel that he has microangiopathy.
This is a very valid point, and that's the whole point of that I started by saying this is a biopsy with 5 glomeruli. He could have had thrombotic microangiopathy. He could have had an associated vascular rejection in another artery. So, and I at that time didn't know the clinical data. He might have had it.
Can I ask a question,
I can't
please?
know.
Is it?
Can I ask a question?
Sure.
The justification of giving the ATG in the presence of CMV.
Why are you asking me?
Who?
Look to the.
C'est moi.
C'est toi.
Okay. Is it safe to make a renal biopsy with this platelet count?
Can we find out who was the clinician looking
Yeah,
at this patient?
yeah, I'm ready now.
تعالى بقى. تعالى سعادة اللواء.
هو في شويه حاجات حضرتك اتلخبطت في الهيستوري. هو الهيستوري disease is a 26 years old man. He presented to us for renal transplant. He received preemptive graft. BRA, in our center we did BRA before transplantation, and even in final course match we did lymphocytometry to be accurate. And he received the renal graft. He started, he readmitted for fever and diarrhea, as we said, and only creatinine was 2.4. And here we shot him. And at the same time, we did CMV. After 3 days, we found that serum creatinine moved up. That's why we shot him and get a biopsy. This is the first biopsy. The first biopsy appeared acute cellular rejection. Just that. At the same time, you have to treat him. We didn't know if it's CMV inducing acute rejection or vice versa. So we push him by, put him on HG, and we found a good response. And we increased the dose of valganciclovir. First, he received ganciclovir IV during his hospital stay, and after that, he continued on valganciclovir, and the creatinine landed to 1.1. After.
Khaled,
Yeah.
sorry, can I ask you?
This is the second time he discharged with creatinine 1.1. After 1 month, he readmitted by this picture, low hemoglobin, low platelet count, anoric. We support him by dialysis, we support him by shots steroid. Even we, as you will see now, we give him plasmapheresis, and finally he got better. And in last week, creatinine was 1.6.
Khaled, this was a CMV negative recipient who had a CMV positive kidney.
No. In our protocol, we give we didn't seropositive from seropositive.
But he had an IgM response.
Yeah, IgM response, and we did PCR also.
So he
It
was
was positive by PCR.
At the time of
Yeah,
transplantation.
yeah. Not at the time of the transplantation, at the time of rejection.
What I mean is at the
لا,
time
we
of
didn't did PCR for preparation of the donor or
لا, but in
recipient.
Egypt, do you check CMV status
Yeah,
of the
we
recipient,
have
and
to.
do you check CMV status
Yes.
of the donor?
Yeah.
So
Of
what
course.
was the CMV status of